Hello friends and welcome back to my channel. In this video we are going to talk about the atrioventricular block, ischemic heart disease or coronary artery disease, angina pectoris and what are the stages of it, myocardial infarction and its complication as a Dressler syndrome. We'll talk about the paradoxical pulse and the aneurysm, and we will talk about the heart failure, left ventricular heart failure and right ventricular heart failure. So let's start. Ventricular block. So block is a condition in which the electrical signals between the arteria and ventricles are delayed or blocked completely. So the symptoms which we are going to see in the patient will be dizziness, fainting, syncope, shortness of breath, chest pain, slower heart rate, because we know that the cardio and pulmo system works together. So we will see heart and lung system in the patient. There are some types of the AV block, first, second and third. So in the first type, what happens is the delayed conduction occurs, but all the arterial impulses will reach to the ventricle. So only thing which you will see on the ECG will be prolonged PR intervals. So more than 200 milliseconds. Symptoms will be usually asymptomatic because still the impulse is reaching to the ventricles. Second degree heart block is divided into two types, Mobitz type 1 and Mobitz type 2. So in type 1 of Mobitz, we see progressive prolonged PR intervals until a beat is dropped, alright. And in the type 2 will be the occasional beat drop. So sometimes we can see the dizziness or syncope in the patient because there is only occasional beat drop. But in type 1, as we can see, the Mobitz type 1, it's just the prolongation of PR similar to type first heart block. In type 3, no communication, the arteria and ventricles will beat independently, and the arteria probably beats faster than the ventricles. So symptoms we are going to see in third block will be fatigue, dizziness, syncope, because it's discoordination in the ventricles of the heart, and it is the severe heart failure. Let's look at the questions. The questions in the crock are related to only third type of the heart block. So you can read both of the question, but let's come to the main key point here. So the patient is the first patient is unconscious, and the patient is having the bradycardia. Heart rate is 40 bpm. So 40 bpm is something very severe bradycardia. So we can assume that what happened in the patient is third degree block. Since we saw the symptom as well, that the patient can faint in the third degree block. The patient is weak, diseased, and short period of unconsciousness. Heart rate is severely low. So mark the arterioventricular block type 3. And you can see the arterial pressure is severely elevated. Why, sir? Why this is elevated? So this is because the heart is trying to compensate it, that the heart rate is very low, but the arterial pressure is raised because the compensation system is trying to compensate the cardiac output. Let's see, the next patient is a child, 16-year-old. So let's come to the ECG findings. Bradycardia is there in this question as well. The ECG finding shows P waves are disconnected from the QRS complex. So we got what we needed in the question, that the arteria and ventricles beat independently in the third degree block. So the arteria and ventricles are beating independently. That's why we are getting the P waves which are disconnected to the QRS complex. So mark the third degree arterioventricular block. Ischemic heart disease occurs when there is a reduction in the blood flow to the heart muscle due to any blockage or narrowing in the coronary arteries, right? So reduced blood flow can lead to various complications including angina, heart attack or heart failure. The primary cause is the buildup of the plaque over there. So atherosclerosis or buildup of the fatty deposits or plaque in the coronary arteries. So symptoms we are going to see in the patient is angina pectoris, chest pain, discomfort. Pain may radiate to the arm, neck, jaw, back, stomach, and symptom may occur during the physical exertion or in the emotionally straining situation, which improves at the rest. So shortness of breath and heart attack, severe chest pain may lead to the may disappear in few minutes. Cold, sweat, nausea, lightheadedness, fatigue in the patient. These are the symptoms which are going to see in the patient. So what's angina? Angina pectoris is the chest pain or discomfort caused by reduced blood flow to the heart muscle, or let's say the myocardial ischemia, so usually due to coronary artery disease. And what are the symptoms of angina pectoris? Especially a chest pain or tightness, which is often described as pressure, a pressure of a feeling of pressure or a feeling of squeezing in the chest. Pain may radiate to the left arm, jaw, or back, triggered by an exertion or emotional stress. Pain can be relieved by rest or nitroglycerin. Shortness of breath, nausea, or sweating may occur in the patient. So let's see some question over it. So a 61-year-old man complains sneezing substernal pain attack which occurs on exhaustion. So substernal pain attack is typical for the angina pectoris. So in the last 2 weeks, such pain appeared at rest with increased frequency and couldn't be suppressed by the 1 tablet of nitroglycerin. So the patient is not responding to his standard treatment. So if the patient respond to the pill of nitroglycerin, that is stable angina, and if the patient doesn't respond to the standard treatment, that will be the unstable angina pectoris. So let's see the next patient. Next patient says a 52-year-old patient with having class 2 angina complains of 5 days of intensified prolonged retrosternal pains, decreased exercise tolerance. Angina is less responsive to nitroglycerin, so he is not responding to the standard treatment. So this is unstable angina. The ischemic heart disease portion, unstable angina. Let's go next. Next is myocardial infarction. Myocardial infarction is the death of heart muscle tissue due to prolonged ischemia from the blockage of coronary arteries, one or more than one coronary arteries. Symptoms we are going to see in the patient is severe pain which cannot be relieved by the rest. Like in angina cases, the pain could be relieved by rest or nitroglycerin, but in the cases of myocardial infarction, the pain will not be reduced in any cases. We need the treatment for that. So the pain will not relieve. Pain may radiate to the left arm, jaw, neck, back. The sweating can occur in the we can see sweating in the patient, nausea, vomiting, shortness of breath, sense of impending doom. ECG shows if ST elevation shows that's STEMI, and if ST shows depression, that's non-STEMI. So let's see some question over it. So there is a driver. You will have to remember this case. Seems a bit atypical to me. So this is a 45-year-old driver having substernal pain. Nitroglycerin is non-effective. He is pale. Heart sounds are regular but weak. Heart rate is 96 and BP is low. So this driver is complaining about substernal pain, which was also typical for the angina pectoris, but nitroglycerin is non-effective. So in the cases of MI, we know that nitroglycerin is not going to solve the problem. He is pale because his heart is not beating, or his heart is not beating well, or let's say in some of the portion of the heart the blood is not going to get filled. So heart sounds are regular but weak because there is not effective supply of the myocardium. Heart rate is 96 because the heart is trying to compensate. BP is low but because even if the heart is trying to compensate, there is not enough blood supply to the heart itself. So the heart is trying to compensate but the BP is still low. So the case of myocardial infection. Remember, there was a 45-year-old driver who had acute MI. All right. So I have wrote something in the corner. The definition of aneurysm. Okay, an aneurysm is basically abnormal dilation of the vessels of the heart system. Let's see the patient. Next patient, question 4. 65-year-old suffered acute MI condition, deteriorated dyspnea at rest, pronounced weakness, edema of lower extremities, ascites is present, heart borders are extended, paradoxical pulse is 2 cm displaced from the apex beat to the left. Sir, what is this paradoxical pulse? We don't understand it. All right, let's see what it is. Paradoxical pulse or pulsus paradoxical in MI is specially when it is complicated by some other things like pericardial tamponade, which is let's say this the pulsus paradoxical paradoxus is the condition where there is more than 10 mmHg fall in the systolic BP during the inspiration of the patient. Why it happens, sir? So during inspiration there is an increased venous return to the right heart, compress the left ventricle due to fluid in the pericardium. So when there is fluid in the pericardium, the heart cannot pump properly, because the heart cannot even fill properly, the chamber will not fill properly, so it will reduce the stroke volume and it will lead to the drop in the systolic BP. The symptoms which we are or it is seen in the patients of cardiac tamponade, which is most common. Most of the time the pathology behind it will be the cardiac tamponade. And constrictive pericarditis, severe asthma or COPD. It is rarely seen in MI with massive MI with the tamponade. Rarely seen, but it still occurs. So let's get back to our case, that he had a case of acute MI. Now he is showing edema in the extremities, and pulsus paradoxicus, paradoxal pulse is displaced 2 cm from the heart apex. So this is the case of acute cardiac aneurysm. Let's go next. Next is the classification of angina pectoris. And let's see it in detail. First of all, the class 1 patients can do a lot of activities. They can walk enough, they can climb enough. So more than 800 meter as classified by the CCS classification of angina pectoris. In class 2, there will be a little bit or slight limitation. So the distance which we are covering is 600 to 800 meters. So they can climb the stairs or uphill, or a little bit they can climb, but lesser than the class 1. Third is marked limitation. So angina on walking 200 to 500 meters. So they can climb a little bit, or they can walk a little bit lesser than the last 2 classes. The class 4 is the most severe class of the angina pectoris. The angina occurs at rest or with the minimal activity. So even with the dressing, the patient is just taking a shower and dressing himself for the school. So he will feel the pain itself in the chest by just dressing itself. So here is the screenshot version for you, that to simplify, remember, for the croc question, this classification is specially for the croc questions, that after remembering about this classification, you will be able to solve the croc question. So you can take a screenshot of this photo: more than 800 meter, 600 to 800, then 200 to 500, or rest pain. A short trick for you: if you will remember from 4 3 2 1, then you will be easy, it will be more easy. Like in the class 4, the patient cannot walk at all. In the class 3, the patient will walk up to some 500 meters. In the class 2, the patient will be able to walk some 800 meters, 700 or 800 meters. And in the class 1, which is the easy class at all, like the patient will be walking enough, like more than 800 meters. So I hope you will understand it. Let's see some cases over it. So you can read the whole question and as well as the ECG changes, but the main highlighting key factor here is that the patient is able to walk 700 to 800 meters. So remember, from the classification, 700 to 800 meter, we are going to class him in the second class. So this was the closest, easiest option: exertional stenocardia, functional class 2. So the patient is having chest pain, yeah, as told in the introduction portion. And ST segment depression, as we see in angina pectoris cases. Next patient is the patient of MI. Okay, so 58-year-old patient complain in the pain in the thorax in the left. Tachycardia is 102, no other changes. Pathology Q wave in one lead, AVL lead, QS, V1 to V3 lead, and domed ST elevation with negative T. So ST elevation, we know through the ST elevation from the introduction portion that in the cases of MI, when ST elevation is there, it is STEMI, so ST elevated myocardial infarction. From the finding AVL, you can remember that it's a left ventricular failure, acute left ventricular anterior myocardial infection. This is AVL finding. I highlighted it here, and this is something the things to remember. They are elevation based. My friend gave me this. I hope it will be helpful for you as well. So lateral MI we are going to see in the lead 1 AVL and lead V5 and V6. Posterior or inferior MI we are going to see in the lead 2, lead 3 or AVF, and anterior we are going to see in the cases of V1, V2, V3, V4 and AVR. So they are elevation based, so in which one will be the elevation of the segment. And however, you have to remember for this question, you can remember this question by this highlight AVL itself, that the patient is having left ventricular failure, and because since there is an ST elevation, so this is the case of acute MI. Let's see the next patient. Next patient is saying that his need for the he is the patient of angina pectoris as highlighted in the first line. His need for the nitroglycerin has increased, so he have to take more nitroglycerin than usual in order to relieve the pain. So this is what type of angina, sir? This is progressive angina, because the patient's need for nitroglycerin has increased. He is not responding well to the standard treatment which was prescribed by the doctor previously. Next patient is able to walk 200 meter. So remember about our classification: 200 meter when the patient is walking according to the Kroc questions. So 200 meter is classification of the third category. So exertional angina pectoris or exertional stenocardia, functional class 3. Next patient is the patient for the angina pectoris. So the problem occur in the patient is for the night several times, 10 to 15 minutes. During the attack, the elevation of the XT segment can be recorded in the ECG in lead 3 to 4. So whenever the attacks are occurring at night several times, and attacks are occurring for very shorter time, so shorter time attacks like for 10 to 15 minutes. So such cases are the cases of fringe metal angina pectoris. I guess there is only one question like this. So remember that what is fringe metal angina pectoris? The patient is having attack several times, but just for a very shorter period of time, like 10 to 15 minutes. So we have to monitor it like throughout the time, and this is occurring at night for the patient. Let's see the next case. Next case is also the patient complained about the retrosternal pain and a 10-year long history of the essential hypertension. And we see the elevation of in the ECG changes. We see the ST segment elevation in lead AVL and V5 to V6. What complication has arrived in the patient? That this was the case of essential hypertension now got complicated with the MI. Yeah, so the closest best option to mark in the question is hypertensive crisis, which the patient already had, got complicated with the acute MI. So you can read the question again. However, let's move to the next question. Next patient says that the pain occurs in response to the physical exertion. he doesn't take nitroglycerin. She was repeatedly treated for ischemic heart disease and had a myocardial infarction. BP raises to a lot, and changes in the posterior wall of the left ventricle. Auscultation reveals the systolic murmur over the aorta. The patient is having pain attack in the heart which lasts for 10 minutes. But the pain occur in response to physical exertion. The question did not highlighted it very well, but just so you know that when the question is saying about pain occurs in response to the physical exertion, so they mean to say that even if the patient tries to move, even if the patient tries to change the cloth, so the pain is occurring to the slightest physical exertion. So you have to consider it in the question that the pain in response to slightest physical exertion is occurring to the patient. So this is the category of class 4, that the patient is having the rest pain here, right? So you can read the question once again. So this is the case of stable exertional angina pectoris, functional class 4. No need to think about it is stable or unstable. The stage 4 was given only in one question. So main highlighting point is here, we classified the patient into the stage 4. Next is about the Holter ECG monitoring. Let's see the case first. 48-year-old complains about the frequent constricting retrosternal pain that radiates into the left shoulder and the left scapula. So pain attack occurs at night at complete rest and lasts for 10 to 15 minutes. So similar case like Prinzmetal angina pectoris. So this is the same case, yeah. So this time the examiner is not asking about the diagnosis. The diagnosis is simply the Prinzmetal angina pectoris. The examiner is asking about the examination method, the choice of investigation method this time. So when the pain attack is occurring at night at complete rest, or the pain attacks are occurring just for a shorter period of time, 10 to 15 minutes. So it means we don't know when to record the ECG because pain is occurring only for 10 to 15 minutes. So we will do the Holter ECG monitoring, which is the 24 hours ECG monitoring of the patient. So remember about the case. The next topic. Next is heart failure. So heart failure basically is the clinical syndrome which is characterized by the heart's inability to pump the sufficient blood to meet the body's demand. So symptoms we are going to see in the patient is shortness of breath and fatigue, edema, coughing, wheezing, rapid or irregular beat. So all the symptoms related to the cardio and pulmo system, yeah. It is classified into two types. Heart failure type 1, which is reduced ejection fraction. So this is systolic heart failure. And because the heart muscle is weak and cannot contract effectively. So reduced ejection fraction we will see in the patient will be less than 40%. Type 2 is the heart failure with a preserved ejection fraction, that this is the diastolic heart failure, that the heart muscle is stiff and cannot relax properly. So it will lead to the inadequate filling of the heart, but failure is still there. Ejection fraction we will see in this case will be 50%. And next is let's see some cases over it. 46-year-old patient, temporarily undetermined diagnosis, prescribed fluorocentesis based on the results of X-ray. So the puncture yielded 1000 ml of the liquid with the properties of clear, specific gravity, protein content. Revolta test is negative. Erythrocytes are 2 to 3 in the vision field. This is the case of the exudative pericarditis. Exudative or transudative pericarditis. I will make a separate video over the exudative and transudative pericarditis. However, this is the case for the transudative pericarditis. In transudative pericarditis, we see that there is the problem with the congestive heart failure, liver failure, nephro failure, or maybe low albumin level. I'll explain this in the another video. I'll make a different video over the pleural effusion. So just for now, know that the If the Rivalta test is negative, this is the case of transudative effusion. So there will be the organ failures will be there. So mark about the cardiac failure. However, we see the conditions given in the question are related to the cardiac failure, but it's okay. Let's discuss it in some another video. Next patient says about during the last several weeks, 11-year-old girl having dyspnea and edema of the shin and fit after physical exercise. After the long rest, edema disappeared significantly and enlarged liver, rasping systolic murmur over the cardiac area, blood and urine analysis without changes. Cause of child edema, heart failure. Why? So let's hear why. Let's see the scheme of it. When there is the left ventricular failure, I am reading the scheme for you. So this is a diagrammatic representation of our heart. Left atrium, left ventricular, right atrium, right ventricular. So we will be getting backwards in the pathology or in the scheme of pathology. So left ventricular failure if occurs, so we will go to right atrium first and we will go to pulmonary vein then, and then we will go to lungs. So problem with the lungs, so if the right ventricular doesn't pump the blood properly, then there will be the blood will get stuck in the pulmonary vein, and then the blood will remain stuck in the lungs as well. So due to which we are going to hear moist crackles, edema, pulmonary edema or moist trails as you see. When the left ventricular failure is there, then there will be pulmonary edema or fluid filled in the lungs. Let's see the right ventricular failure. So we will go backward in the scheme. In the right ventricular, the blood is coming from the right atrium, and in the right atrium, the blood is coming from the inferior vena cava or superior vena cava, or let's say in the inferior vena cava is bringing the blood back from the leg portion or the lower portion of the body. If the right ventricular got failed, so the blood will stay in the legs for sure. It will not be able to come out. So we will see peripheral edema like the leg edema or the shin edema. And due to the superior vena cava will fail to bring the blood back into the ventricle in the right heart portion, so we will see the jugular venous distension. It means simply we will see very high pressure in the jugular venous jugular vein. So we will even notice it around the neck area that the jugular vein is distended very well, that it will be visible physically in the patient. So we will remember it now. So let's make a mnemonic for it. When the left ventricular failure is there, so there will be lung edema. When the right ventricular failure is there, then there will be pulmonary edema. So left means left failure is related to lung, right related to the rest. This is the mnemonic which you can remember, because you will not be able to get the enough time in the exam to draw this scheme or to draw the heart diagram and try to think the scheme. So this is the short version of it. You can take a screenshot of this as well as the last photo, that when the problem is with the left heart, lung edema will be there, and when the problem is with the right heart, the rest of the edema will be there, that like the jugular venous distension and the peripheral edema will be there. All right, so now we can get back to our cases. So during the last several weeks, 11-year-old girl having dyspnea, edema of the shin and feet after the physical exercise. After long rest, the edema disappears significantly and enlarged liver, rasping systolic murmur over the cardiac area. Blood and urine analysis are without changes. So you know that why the edema of shin is there this time. That shin edema is caused by the heart failure, right? That the peripheral edema or shin edema is the cause of right heart failure. However, right was not in the option, so heart failure was in the option. So this is the case of heart failure. Next patient says that he is having asphyxia attack, 15-year long history of the essential hypertension, and had a myocardial infarction 2 years ago, and position of her in the bed is orthopenic, skin is pale, patient is covered with the cold clammy sweat, and acrocyanosis, pulse is high, BP is very high, respiration is high. The patient's condition are gravely given in the question. The pulmonary percussion sound is clear with the slight dullness in the lower segments. Throughout the lungs, single dry crackles can be heard in the patient. The pulmonary edema case, you know that in the pulmonary edema is related to the left failure. The question is clear now, right? Without even thinking a lot. So when there is pulmonary edema given in the question, so we know from our scheme that lung edema or pulmonary edema will be the case of left ventricular failure. However, if the left ventricular got failed and if the proper treatment will not be provided to the patient shortly, the patient will be even the right heart will get failed very shortly. So one-sided heart failure means the failure of the other side of the heart as well very shortly, and the failure of the pulmo system as well, since they work together. So I hope this is clear now. Here I have provided the well-detailed explanation for the heart failure, the right ventricular failure and the left ventricular failure, which we just saw in our diagrammatic scheme. So I just wanted to, you can read it, you can even take a screenshot for all of our schemes as well as the beautiful notes of it, so that you will remember it in the long-term memories, and you can build up the concept very well just before the exam. And I wanted to highlight this part because our last patient had the left ventricular failure. So I just wanted to highlight the part that acute left ventricular failure doesn't mean that the problem is confined to the left ventricular. Now if the patient doesn't get the treatment, now he will have what problems? Let's hear it. I'm reading the lower part after the last key 3 points. So one side of the heart fails means the congestion in the proximal part, right? The fluid will not be, or the blood will not be able to pump ahead. So if the treatment is not provided, after some time another side of the heart also fails. Congestive heart failure by the CHF estimation or this criteria. However, you don't need to know the criteria for the croc questions. So ischemia on one side and congestion on another sides. So there will be the mismatch in the cardiac output of the heart through different parts of the through different chambers of the heart. So what happens is there will be ischemia on one side and congestion on the another side. So I hope this time it is clear now. Let's go next. Next is the Dressler syndrome. So we have seen that what is MI. So what happens is that after some days, or let's say the croc question says some 4 weeks or some 13 days. However, 2 weeks is more common for the Dressler syndrome. So we have seen MI. So Dressler syndrome is a complication of MI. It is the direct question. Sometimes the croc examiner is asking that what complication has occurred in the patient after the case of MI. So this is Dressler syndrome. Let's see what it is. Post-MI condition develops after 2 to 10 weeks. It's an autoimmune reaction, which is pericarditis, pleurisy and arthritis together in the patient, which is a severe condition of the patient. So what we are going to see in the patient: chest pain, fever, arthralgia, pericarditis, pleurisy, and ESR is elevated, leukocytes will be elevated, ST segment will be elevated, and treatment will be NSAIDs, corticosteroids, syncytials, pain management plus inflammation management, pain management plus the immune suppression. So the question says, 4 weeks after a case of MI, 52-year-old patient has increased body temperature, pain in the heart area behind the sternum, in the sides of his torso, pain increases during breathing. Examination shows a few days later developed arthralgias as well. Examination shows pericarditis, pleurisy, arthritis. The blood shows leukocytosis plus ESR. ECG shows the ST segment elevation. So I hope you got the case already. So this is Dressler syndrome. We got all of our pathologies in the patient. However, let's see the next patient. Next patient had problem on the 30th day. 13th day, the patient developed the chest pain after the treatment of myocardial infarction. The patient on the 13th day complained about the chest pain, shortness of breath, fever, fine bubbling rails or fine bubbling crackles can be heard under the shoulder blade. On the 15th day, he was diagnosed with the right-sided exudative pleurisy. We got our pleurisy as highlighted in the symptoms. We got the pleurisy. And next, the CBC profile. You can see the CBC profile. So eosinophils, something is allergic reaction or autoimmune reaction we see in the patient, that eosinophils are elevated in the allergic reaction or autoimmune reactions in the patient. And this is the question which was asking what complication of MI developed. So we know that the complication of MI which got developed in the patient is Dressler syndrome. So this is it with this video, and let me know in the comment section if there is something which you are still marking as incorrect. We will discuss it in the comment box itself, and wait for the next video. I am trying to cover more topics over cardiology, so wait for it. Have a nice day.